not respond to a therapy. What we do is I ask for a biopsy. And very often, I will say, in the genital warts papillotype that has not responded to a standard therapy has turned out to be a pre-malignant condition known as Bowenite papillus. I'm sure you must have heard of it. It's a pre-malignant condition which has to be excised. So when in doubt, what we do is always take a biopsy, but 80 to 90% will actually be treated with our podophyllin. Now comes a problem. Podophyllin is contraindicated during pregnancy. So when a pregnant woman comes with the genital wart, then we have got two options. What we do is the medical therapy give 80 to 90% trichloroacetic acid. It's just a cautery type of chemical, just like podophyllin, 80 to 90%. But the preferred actually is cryotherapy, which I'll come to later. So when in our dermatology point of view, when the medical therapy fails, we use the agents I mentioned. Then we go to certain surgical measures. Of that, I would say the best will be liquid nitrogen cryotherapy, that is minus 196 degrees centigrade. Now, cryotherapy has got a very good advantage because it does not require any local anesthesia. Number two, it can be given in pregnancy. The equipment is very easy to handle also. It's very, very, very effective, I would say. And suppose the patient still does not respond to cryotherapy, we got another alternate, which I don't use often, but we got an carbon dioxide ablative laser. Ablative laser. Okay, if your equipment is very good, you'll get good results. Otherwise, okay, it is there. And then comes a problem. In spite of all this, sometimes in addition, we can do, even though we don't use it much, you can do a simple electrocautery for small warts. But I mentioned in case of the penis, you may have to give a root block, it will disappear. But then sometimes you find that all these therapies will fail. Then you have to reconsider your diagnosis. And often we send to the urologist for a biopsy. Now, there's another important thing. Sometimes you may get the commonest sites of this warts usually are the glans penis. And you can get the shaft of the penis. Of course, in MSM activity, you can get in the perineal region. But sometimes you may get an intraurethral wart. Of all the things I have told, it may be very difficult to treat. You cannot apply chemical care. It will cause severe irritation. When I encounter intraurethral wart, then I refer to our dear urologist. I think excision is the best thing. The second condition where is when you have a so-called giant condyloma accuminata, very large lesions. Now, this one thing I said in pregnant women can be because of the immunosuppression, but in a male patient coming to giant genital warts, I would say you please send for a retro infection because giant genital warts are very commonly seen in HIV infection. So much things that can be done. Again, still then you plan for a biopsy, and a very important mimic of a giant condom acuta is a condition occurring in the penis, a verrucous carcinoma. It can occur in females also, which is a well-differentiated squamous cell carcinoma. That situation we refer to urologists for a complete excision. And another situation where we come as a problem is a pregnant woman has got near labor, almost full term, has got condyloma accuminated lesions on her genitals. Now, what to do? Often we dermatologists get a call. If the lesions do not block labor, you can ask for a normal delivery. But if the lesions are large and obstruct the introitus, then we can ask for a lower section, cesarean section. Then comes a question, people say, I have got a genital recalcitrant. Is there any role for the HPV vaccines? Now we got bivalent and even a quadrivalent, is the Cervarix and the Gardasil. Reports have been shown that you can concomitantly give this vaccine because these vaccines are immunomodulators. They are effective, but Government of India, that is our organization, NACO, National AIDS Control Organization, now is advocated compulsory all females aged 9 to 13 to compulsory take this vaccine. It's going to come as part of a vaccine program. So I would just wind up saying that in majority, medical treatment will suffice. Second, most important is cryotherapy. When all this fails, please don't forget to take a biopsy, and then we can refer to our dear urologist friends. Okay? Any doubts or questions I can take?
Sir, the first question is there any way of transmission other than sexual transmission? Because we
Yes,
have
yes,
seen so
okay.
many.
Right. That's a very important question, especially medical legal point of view. For example, if you have got, see, the genital wart, use the term genital wart, but you can get a normal wart that is caused by human papillomavirus, different serotypes, 1 to 4 in the fingers are. That is known as verruca vulgaris. This can be auto-transmitted to your genitals or even the perineal region. It is always possible. That is there. Now, here comes the important medico-legal problem. I have gone for many situations as an expert. They got a child. Nowadays, the POSCO law is there. Now, this particular child has got, according to the clinical examination, a genital wart on the penis or perineal region. Now, there is no way this child has got any sexual contact by itself. So, if it is abuse, is one possibility. Nowadays, when we suspect, we immediately have to inform the police because of the POSCO Act. And now comes a little bit of a pitfall. When before you actually commit as a case of sexual abuse or something, you please carefully examine the child or the caregivers. Have they got warts on the fingers? Because this can be automatically transmitted. So auto inoculation can occur, which means genital warts is not solely transmitted sexually. Even auto inoculation from your own body or somebody else, verruca vulgaris can be transmitted. Yes.
So, apart from that, apart from a sexual contact, suppose
Yes.
somebody is having some other contact, like they are using the bed linen, they are touching that area.
Right. Okay.
Is there any
There
chance?
is no transmission of HIV by fomites, by clothes, cotton. No, there is no way you can transmit by fomites because the virus is too fragile to survive in fomites or external surfaces. Yes.
So, while doing surgery, do we need to take any precaution that we don't get it?
During surgery, the only thing, because it is a human papillomavirus, it occurs by mistake if you get when you're doing the surgery, if you get when giving a local or something, if you get an accidental prick either by injection or by suturing or something, then it is possible it can be transmitted into your skin. It is possible.
It will be coming only to your skin, or
No,
which
once it
particular
is
area will come?
it is a DNA virus, it's actually confined the epidermis of the skin. If there is the presence of the surgery, so that virus is there, short period is there, it can be transmitted to the skin and you can get warts. That risk is definitely there.
Dr. Vineet, any questions from your part?
I think this has answered pretty much everything that I had in mind.
Thank you.
Yeah, and
Thanks.
Raghavendran, yeah.
Yes, sir. So regarding the vaccinations,
Yes.
what is the difference between Gardasil and as well as Cervarix? And what is the course? Is it 016 or
Okay,
just
yes,
only
it
two
is.
doses?
Cervarix is a bivalent vaccine, whereas Gardasil is quadrivalent. We prefer the quadrivalent. Why the government of India has advocated this is because we all know the HPV type 16, 18, 30, 31 are oncogenic strains. So the primary role of giving this vaccine children is not only to prevent HIV infection, but also to prevent CS cervix. So actually worldwide, the quadrivalent vaccine is actually advocated, but there are other strains also which can be oncogenic. So basically India is 16, 18, 30, and 31.
So
And
here, how many doses?
it is given as 4 doses, 0.5 ml, and one cost depends upon the company or the manufacturer. Hindustan Serum Institute is it comes 2,700 to 3,800. That is the cost, 2,700 to 3,800. In young females, 9 to 13 years, the government of India is going to give free, most probably from January 2026 as a part of the national vaccine program.
Sir, there is a recent article which is showing even this Gardasil is having a therapeutic effect.
Yes,
Is
yes,
it
it has
so?
got a it has got a therapeutic effect because when you're injecting a vaccine, you're boosting the cell-mediated immunity of the patient. Naturally, sometimes the HPV will disappear. Yes, it has got it has got definitely therapeutic effect also.
So is it once for all one course of vaccination, or they need any booster doses?
In case of, if it's a case of recurrent genital, what's a booster may be required. A booster may be required. Otherwise, a single dose is more than enough. But very often recurrent type, and especially if the patient is retropositive, you may have to give multiple doses.
So other than this podo, what any other topical things?
One I said is trichloroacetic acid.
Trichloroacetic acid.
That these are the two things which we give. Then there is one agent. See, all these are actually physician applied. There is one agent, since you asked that, I should mention, which can be, the patient, that is 5% imicumod. Hope you have heard of it. Heard of it?
Yes, sir.
It is,
Yes.
that is an immunomodulator which the patient by himself or herself can apply. It is given thrice weekly for 12 to 16 weeks, pretty expensive. And my personal experience, an all and none phenomenon. If they respond, it's excellent. If they don't respond, it's absolutely useless. I would say 50-50. It's expensive, very expensive, and not available all. But it is advocated, especially when you want the home treatment or the patient wants a home treatment for the warts. And in pregnancy, you can only do TCA or cryotherapy. Even this is contraindicated. It is
So
available
regarding
as
this
yes, continue. Yes.
podo what? Regarding this podo what? Only 2 applications with 1 week apart,
In most of
or
the patient will respond to 2 to 4 applications. But
2
if
to
you're
4?
going for more than 6 applications, I suggest review your diagnosis or take a biopsy.
So is there any limitations that this is the size where we can apply medical therapy with
Yes, yes,
Podovat?
that
Size
is what.
criteria?
Okay, okay, that is a very pertinent question. We cannot apply more than 0.5 ml podophyllin, but not more than 10 centimeters square, because podophyllin can be get absorbed and it's a nephrotoxic drug and CNS toxic drug also. So not more than 0.5 ml and not more than 10 centimeters square in a single sitting. That is definitely there. But very often we don't encounter such large lesions. Whenever you get a large lesions, we prefer a cryo or an excision.
Sir, I had a patient which was sent by
Okay,
Sunil, Dr. Sunil. He had he was actually widower, but he has a partner. So he got a genital wart, but he says
okay,
his partner is not having it. Now the question is whether he got it from somewhere else, or it's a different question. So I have
okay,
excised it. So his question is, what should I do to prevent my partner getting it, or what should I do to not getting it recurrence from the same partner? He doesn't
okay,
want to use a protection.
okay. But here, actually, this patient, I would ask his partner, a female, to have a gynecological examination, because in females, sometimes the warts can be cervical warts, which may not be visible clinically. So if his partner was having the cervical wart, he is not going to know, he'll go on getting recurrent wart. So we do a gynec examination and rule out the cervical wart. The cervical wart is managed only by a liquid nitrogen cryoprobe. The gynecologist do. And
And
if he does not want to take any protection, we have to tell him that first of all, you investigate his wife. If his wife does not have any cervical wart, then his history may not be right. Then the question is how he got the wart. But then we
uh,
can tell him that if his wife does not have the genital lesion, he can transmit it to his wife if he does not use protective measures.
is there any way the vaccine is going to protect him or his wife or anything like that?
Okay, according to the theory, because it is a preventive vaccine, by giving that, it may give a protection. It may give a protection, because I have got many reports saying that people who have taken this, there is no 100% protection. That is not. But it may protect. If the patient is willing to take, he can take.
So if
No.
he's 40 years or 50 years, we can advise
Yeah, there is
vaccine.
an adult vaccine you can give easily. You can give, but you may have to give a booster dose. But I think the best thing will be you counsel the patient, tell him to get his wart treated. Then you examine his wife by the gynecologist, no problem. And you treat that, the wart disappears. Then we can actually advise him to have no problem contact.
And at another question,
Yes.
he had a wart, we excised it.
Okay.
So his question is, suppose he is going to another partner, is there any chance of transmitting to the another partner? Because we have excised the already present warts.
Okay.
So is there any chance of him transmitting to another partner?
The what is completely excised is very unlikely that he can transmit that particular genital wart to his partner. Very, very unlikely. But it must be taken that it has been completely excised, and also may ensure that the patient does not have an urethral wart, because then he can test. Otherwise, there is no problem.
So do you think that it is better to do a urethroskopy for all patients with a genital wart?
I think you see most of the genital warts, if the affects, if it's confined to the external urinary meatus. So I'd say we can just do a clinical examination, because if you're doing a urethroscopy, there is a chance you may implant the wart deep into the urethra. Then it may be difficult to treat. Most of the warts which I have seen is usually extra urinary meatus. We can easily diagnose it. Then usually I refer to urologist for excision. Doing an urethroskop may push the HPV further into the urethra. Then we may have difficulty in treating such people.
So any precautions we need to take? You sir has already said it is a very fragile virus. So that should
Yes.
be easily destroyed in our routine autoclaving process.
Yes, yes, it is easily destroyed. It's very fragile virus.
So there is no need to take extra disinfection for our instruments
No,
and
no,
other
no,
things.
no. Unlike hepatitis C and HIV, there is no need of any protective. No, absolutely no need.
Is there any chance of it spreading by inoculation? Suppose I'm touching a wart,
Yeah,
and
that by simply touching a wart with your finger, it's unlikely. But suppose we got a microscopic trauma in your skin, then there is possible. But very often in surgeons, what happens is they may injure the during the process. Suppose they're doing this, they may injure their fingers either by the suture needle or by the injection needle for local. Then it can be transmitted. Otherwise, it's very unlikely. By touching a wart, extremely unlikely. But of course, we always use gloves to do it.
any Raghavendra questions?
Yes. As a extension to your question, sir, same thing. One couple have where
Okay.
husband has got genital wart treated with
Yes.
podophyllin with 2 doses,
Okay.
completely cured. Wife has undergone gynec examination. She is
Okay.
completely fine. She has
Okay.
advised Gardasil vaccine,
Yes.
and even I told the husband to take the same vaccine. But the
Yes.
question is, am I completely having a cure? Is it any
Yes.
way we can test other than lesions examination or histopathological examination? Is there any serological test? Is there any way? That is
No,
the
no.
question.
No, there
Because
is no
it,
serological test to diagnose HPV, because HPV infection is confined locally to the genitals or the sites. It is not a blood-borne. So no serological test is actually going to diagnose that. If it has been completely treated, completely excised, it is most probably gone. No problem. There are no serological tests to diagnose HPV. But sometimes in the lesion, you can do certain tests. For example, in a medico-legal case, for example, case of assault, you know, that and that person, the survivor has got a genital wart or a perianal wart. And what happens is, I have got occasion to go to many as an expert witness. The defense is simply going to ask me one question. So it's suppose like my partner previously had a wart on the fingers. Can it be transmitted by that? I can only say yes. Under such situation, you can take a histopathology and send for HPV type. That is done in a regional cancer to Trivandrum. Type 1247 causes the common wart, whereas 6 and 11 is usually and only sexually transmitted. So if you got that histopathology serotyping, you can convince it that this is sexually transmitted and not autoimmunization.
Suresh Bhatt sir, any question, comment, sir? Dr. Arun Chawla? Dr. Sharik, anything more to add from the ID specialty?
No. From the ID perspective, nothing. All has been tackled. All the questions have been answered. Basically, the HPV vaccine. So everything has been covered. Nothing from the IDC because we don't have any specific virals or something like that. So all the questions have been answered. Thank you.
So can you comment about the vaccination for young boys? At what age group should we give and how many doses?
Dr. Renu Thomas here.
Is it,
Yeah.
Yeah.
is it to me?
Yeah, sir.
Yes, Pradeep sir, I was
Yeah.
asking you.
Okay.
Yeah, basically, we can give in between 9 and 16 years, it is 2 doses, 0 to 6, 2 doses. And if it is between 16 to 26, it can be 3 doses, 0, 2, and 6. The 3 doses we give in more than 16, and 9 to 16, we give 2 doses.
Okay, thank you, sir.
There is one misconception or belief which is being there in the urology circle, which has been discussed sometimes. I don't know the scientific basis. When you are doing a cautery to the warts, even the fumes can transmit the disease. I don't know whether it is right or wrong, but it is.
No, that's a very good point here about Dr. Vinod. Actually, whenever you're doing a cautery, actually I said one option is actually a carbon separated laser, or you can do a simple electrocautery also. This is not a feature for a cryotherapy. No. Actually, when you're doing a cautery, you're applying a high frequency current and temperature to the lesion, and you're cauterizing the lesion, which will release smoke, fumes, etc. And unfortunately, it has been scientifically proved live HPV virus has been located in these fumes. So whenever doing a cut, of course, we put mask, no problem. We require a smoke evacuator for laser also. Live HPV virus has been demonstrated scientifically and published also in the fumes of the cut. The smoke evacuator is mandatory when you're doing ultrasound.
So that is needed only when you are
You
cauterizing
use
over the
either a
lesion.
calm separated laser or an electrocautery, not required for cryotherapy. Not required for
No, usually what we do is we just excise around we put an
that. There's no need of a this thing because we are not cauterizing or releasing fumes or anything.
then it is
Your
fine.
news, Haryana man buys a cake to surprise his wife on birthday, midnight, but falls asleep. Why?
Sir.
Yeah, Raghavendra.
Yes, sir. So while applying this podo, what are there any
Yes.
precautions? Because the
Yes,
surrounding
very
skin also
important,
been
very
touched.
important. What is an corrosive antimitotic agent? It is always physician applied. Never tell the patient to apply it. Before applying pot, because it's a corrosive substance, you will have to put protective Vaseline around the lesion, not into the lesion. If the Vaseline goes into the lesion, your body is not going to work. So put it around the lesion, then you apply because sometimes this is a lotion, it can spread. If it spreads to the surrounding skin, severe necrosis. Look, I even seen a case of gangrene of the penis where the urologist have to amputate the penis. That because the patient applied by himself. So it's a very corrosive substance, and moreover, it's a poison. It has to be kept away from children. It is a poison. You have to apply protective. That is why it is always physician applied.
Dr.
After-
Rajalakshmi, you have anything to add, Dr. Rajalakshmi?
Yeah. So I think only cautery is a concern, and then definitely you should wear a mask. Other mode of transmission, I mean, surgical transmission is less likely. Anything specific that I would like to answer? I mean, question, you can ask me.
Dr. Kannan sir, are you online? Dr. Krishnasamy Kannan? Dr. Rajiv TP, any doubts or any opinions? Okay. I think we have covered all the questions, and Pradeep sir has clarified all our doubts also, and Dr. Sharik and Dr. Rajalakshmi also contributed.
I joined late because of the traffic block. No, 1 hour road.
Okay, that's fine. That's fine. So we, sir, shall we move on to the next topic, sir?
Yes, sure.
Yeah, this is one strange situation the surgeons usually face. We usually send for all viral screening, and previously we used to send for VDRL for all patients. Later on, we stopped it. Many consultants are not doing it. But of late, we are seeing more cases, and we are sending for VDRL positivity. Now we get old patients and young patients VDRL positive, but they are not symptomatic. So how we should approach this patient?
This is actually a problem faced universally, not only by urologists, even by the blood bank people, gynecologists and dermatologists. Now, routinely, usually before prior to surgery, I suppose we do retro hepatitis B and C. Routinely, VDR and TPH is not done, but is done by the gynecologist for the obvious reasons. So, as you are right, routinely for a surgery, VDR is not required, provided, of course, we take the proper universal precautions. But the problem comes when routinely you do VDR. Doing VDR alone is not going to be of much help. You send for VDR, retro-negative, hepatitis B, C, non-reactive, VDR reactive in for dilution. Now, that does not convey anything because VDRL is a non-specific test. A large number of biological false positives can occur. So if ever you want to rule out asymptomatic syphilis, you will have to combine the VDRL with the specific test TPHA. If both are positive, then by definition, it is not a biologically false positive. Now, Dr. Vinod just said the scenario, no clinical signs and symptoms. This is now the commonest type of syphilis we see in dermatology. VDR positive, TPHA positive, no clinical signs and symptoms. And this is known as latent syphilis. Now, why this? Okay, we don't see the classical primary chancre second syphilis when I was speaking. Reason is simple. It's because of the rampant and over-the-counter use of antibiotics. Say the patient has got syphilis. He has developed syphilis, he has developed a rash of he does not know, nobody has diagnosed. Now, he goes for respiratory infection, he goes. Nowadays, fortunately, the government has strict tools on it. Now, who among us has not taken a course of azithromycin and amoxicillin? All of us take. Now, this fellow will take azithromycin, amoxicillin, an unrelated respiratory problem, and this, unfortunately, this antibiotic is effective for syphilis, partially effective. So, what happens? He must be having early syphilis. This antibiotic partially cures it up, and that is known as happenstance treatment or by chance treatment. He has taken this, and then say he has gone to donate blood, and then suddenly comes his referred to department. VDR positive, TPHA positive, but no clinical signs and symptoms of syphilis. That is known as latent syphilis. That has occurred mainly because all his clinical signs and symptoms were partially cured by the antibiotic he has taken. One situation. But a person has developed syphilis even without treatment. Normal course of the body's immunity can ultimately reduce the infection and the patient non-reactive. So when we get a report as VDRL positive, TPHA non-reactive, no clinical signs, it is syphilis, latent syphilis, and you will have to treat it. Until otherwise, the patient was a previously known case of syphilis. See, one thing should be kept in mind. Once you treat syphilis completely, the TPHA is going to remain positive throughout life. It is not going to become negative and non-reactive. So we again the same situation. A person has come for urology, say for a prostatic surgery, and Dr. Vinod says it does not send for VDR, but you send for VDR. It has come as VDRL non-reactive, third senior, TPHA positive. Now, you carefully take the history. If the patient says has got records suggesting that he has taken treatment for syphilis, then this becomes a serological scar. It is the scar of the original syphilis. There is no need of treatment. But the patient is not sure, and the patient does not give any that is a document recorded by a physician that he has not taken treatment for syphilis, then you will have to treat it as a latent syphilis. The treatment we give is benzathine penicillin 2.4 milligrams weekly into 3 weeks. In some hospitals, they don't give benzathine and not named crystalline penicillin can be done. So, if you get a report before surgery and no record that he has been treated previously and no clinical signs of symptoms of syphilis, that is what's in nowadays. You have to treat the patient for the patient's benefit and for the surgeon who is going to do the surgery. Then we got another situation. This particular patient, we have given, say, 3 doses of benzathine penicillin weekly. As I told you, the TPHA will not become negative or not. Throughout life, it will be there. Now, here comes a problem regarding the immigration point of view. Before immigration, we know retro test TPHA VDL is mandatory. If those people see TPHA positive, they are not going to give you visa. Goodbye. Very often in a government medical college, they give us certificate saying that he has been fully treated, this whole cervical scar. They may or may not take it. That is there. Now, conversely, another condition. Again, the patient's taken treatment, VDR positive, TPHA positive. TPHA I said we positive, but the VDR initially it is 1 in 8, then 1 in 4, then 1 in 2, then 1 in 2, 1 in 2, 1 is not being non-reactive. Now, this the patient will be really distressed because according to him, your disease is not cured. He'll come and say, what is this? I took 3 doses of your benzathine. I took 20 days of your crystalline pills. What is this? Then there is a condition known as zero fastness. That is, the VDL will not become non-reactive. Does not indicate any disease. A patient has been fully treated, but it fails to become non-reactive because of the commensal spirochetes present in the genitals. So you just reassure the patient. But again, the problem comes when the patient is going for immigration purpose. That is always there. Then we got another situation, Dr. Bingo was saying to send a routinely. So suppose a patient has got a very recent contact, say the incubation period of syphilis is 9 to 90 days, but 2 to 4 weeks, say just 1 week before he has got a contact. So then there won't be any clinical signs and symptoms. Or and suppose before surgery for urology, you're sending for the blood. He has actually has got syphilis in the system, but not clinical management. The VDR will be non-reactive because VDR takes some time to become positive. This is almost akin to the window period in HIV infection. Very often we send for retro tests also, but don't take it for face value retro negative because during the window period, the retro test will be negative. In early syphilis, the VDR will be non-reactive. Then the only way to, we have got certain very important tests. Of course, nowadays we can any lab and offer you PCR tests. So even though when you're sending for a panel before doing surgery, that negative result always to be taken in what you said brackets. Then comes another problem situation in surgery is when patient is HIV positive and he's got syphilis also. Now, full-blown HIV patient, AIDS patient, who has not started ART, the VDR will be false negative. Will be false negative. So that only way to diagnose then will be by if the patient has got clinical signs symptoms, you have to do a dark field microscope. And conversely, during early stage of HIV, sometimes you get a very high titer positive VDRL with the TPH remain negative. That is known as again a biological false positive. So during early syphilis, the VDR will be non-reactive. So these are the different situations how we interpret of this. The most difficult thing which I find in dermatology is the zero fastness and the TPH being reactive throughout life, which is very concerning to the patient. And many patients, in my experience, what they go and take repeat injections from some other hospital, multiple injections. Still, it's non-reactive. Still, it is non-reactive. This is regarding VDR. Any questions?
Sir, suppose this patient is not ready to take a treatment, then can we proceed with the our procedure? With
absolutely no problem. If you are using the proper universal precautions, you can do it. But you tell the patient, syphilis, this is how I frighten the patient. STI patients are very scared. I tell syphilis will affect your brain and your heart. Neurosyphilis, cardiosyphilis. and you're going to be really suffer. He will take the treatment. He will take the treatment.
Okay, so this crystalline pencil and benzathine pencil are routinely available.
Actually, the NACO recommendations benzathine pencil 2.4 microns weekly in the 3 weeks. But many, or even our government micron Alapura won't give benzathine. I do not know the reason, because on particular time we had 4 or 5 deaths due to benzathine pencil. Alternative which we give is not in the recommendation. We give a crystalline pencil 20 lakh 6 hourly for 10 to 20 days. 10 for early syphilis, 20 days for late syphilis, such as out of over treatment, but it works out. Benzathine is a problem. Very few hospitals get because of the dreaded anaphylaxis. But now NACO is saying it is not that common to cause anaphylaxis. I don't know about the experience of other dermatologists.
So this 6 hourly crystalline pencil means this patient has to be IP for that.
Admitted for 10 to 20 days. So then comes a problem. None of the patients going to even government. No, not possible, not possible. And as carrying your heart, brain, no problems. I am not going to come as IP. Then the second alternative is provided any case of latent syphilis in a government medical college, we do 2 mandatory tests. One, I send to cardiology to rule out cardiovascular syphilis. Number 2, I send to neurology for an LP, because many patients with VDRL being reactive, TBHA being positive, can have what is known as asymptomatic neurosyphilis. There won't be any signs and symptoms, but this patient, when doing an LP, will find evidence of the CSF being positive for VDRL. But our organization, NACO, National AIDS Control Organization, and the American CDC says that if there are no clinical signs and symptoms of syphilis, no need of doing LP. But I beg to differ, because I have done a personal study and published. I have seen patients diagnosed as latent syphilis, but the CSF has shown the patient to be VDRL positive. This patient had actually asymptomatic neurosyphilis. Now the question may be asked, why again treatment? Only crystalline penicillin can cross the blood-brain barrier. Benzathine won't cause. The alternate will come to later, also won't cause. That is why I, in my setup, does LP, but the recommendation is not to do LP if there are no clinical signs and symptoms. Now, Dr. Vinod asked what alternative. Patient is not going to be admitted for 10 to 20 days. If the LP is positive, there is only one treatment CP. Alternative is tab doxycycline. Taken a class in early and late syphilis, 100 milligram BD into 14 days for early syphilis, 100 milligram BD into 28 days for late syphilis. Of course, I would give pantoprazole attack, or is going to come with the gastric. That is an alternative. Then comes the problem. Suppose if a pregnant woman comes with syphilis, the same situation, we cannot give doxy, allergy to penicillin. Then what they say is the alternative ceftriaxone injection can be given 1 to 2 grams for 10 to 14 days, but we are not considered headache of the gynecology. So doxy is an important but not as effective as penicillin in syphilis. In syphilis, still penicillin is the drug of choice, and up to now we have not reported resistance of Treponema pallidum to syphilis.
Sir, suppose this patient has come and we are doing the surgery. Is there any chance, suppose we are not taking or we have failed in the universal precautions at some point, is there any chance of it being spread to another patient?
Yes, syphilis can be spread through blood, and that is known as syphilis DM, especially get a deep penetrating. Syphilis can be spread. Very often people say that I have not got any contact and how I got syphilis. In any case, if the history is right, sir, I got a needle prick injury, it can be transmitted through by needle prick injury or by suture.
So I think then it should be one of the screening tests mandatory.
It should be, because it is not only for our safety, for the patient safety also. I told untreated syphilis is very dangerous. The patient one fine day will go with neurosyphilis and even cardiovascular syphilis. There is no harm in doing. There are no guidelines saying we should not do, isn't it? Previously, I think when the HIV was a pandemic, there were big guidelines saying don't routinely do retro tests. Now it's not that. It's for our protection for the patients. We want to know the HIV status. You can do. I think it should be done for patients' benefit and for our protection. It should be done. But I caution you, VDR alone won't help. Please combine with TBHA. Most of the labs will do it. And the public health lab also does it free, VDR plus TPH.
So, any comments, Vineet, Rakhavendra, or but sir, anybody is doing this routine screening? I just started recently because of the increased incidence. I was just starting to do it, and I could find a few cases. That's why this has been discussed.
No, I think this is
One point, we know that the cardiology people angiogram routinely now they do this. Routine angiogram.
Okay.
Routinely they do VDR and TPH because as we know, they said they have got a lot of cases that is positive. Yes, continue.
no, in fertility, we are seeing this being done. But if I look at general practice, we're still not getting VDRL testing done with the other viral markers. And I think it's high time we should start reintroducing this.
Should be done.
We should start reintroducing this. Absolutely
Yes.
agreed.
Dr. Rajalakshmi, how is in KIMS?
So can I add few of the points?
Yeah.
Sure.
So one thing is we routinely give benzathine penicillin, not crystalline penicillin, unless we have meningitis. We have it in our pharmacy. We don't have a problem with penicillin allergy. For the first
Yes,
dose,
that's true.
the test dose. But after that, if they come first, after 1 week or second dose, after weekly intervals, we don't do test dose because that is not required. Even for penicillin, no known allergy, no recommendation for doing a penicillin test dose. But since we are injecting a large volume into the buttock, we give penicillin test dose for the first dose, but it is benzathine penicillin routinely that we give. That is a drug of choice. We also use for benzathine penicillin for many other conditions, including prevention of recurrent streptococcal infection in filiary lymphedema. So it is very much available, and we have been using for the last 12 to 15 years without any shortage.
Yes.
I think we can definitely.
That is the drug of choice we could NACO, but our hospital, there are certain rules. Yes.
And it is preferred for neurosyphilis.
Yes.
Number 2, regarding CNS, if you have autosyphilis, that is an indirect evidence of CNS syphilis. So if you have any patients with ear symptoms, we routinely evaluate for autosyphilis and definitely proceed with CSF study, because then the drug of choice is crystalline penicillin. And we have low threshold to do a CSF for HIV patient who is syphilis positive, because they can have neurosyphilis. So if HIV positive patient has syphilis also, and you have any symptoms, you have a low threshold, proceed with CSF, because that matters in further HIV treatment introduction and so on. Then now we have CDC has introduced a reverse testing algorithm. So usually what we do now is a non-treponemal test, that is either VDRL or RPR. The difference between RPR and VDRL, I think we would have discussed. RPR is a rapid test, so it is done for ease. VDRL a little more stepwise test, and it takes few days for the results to come back. And there are a lot of interpreter variation even in RPR, because it is a visible thing, flocculation. We have found so much error, and we have asked them to redo, and it has become negative. So I have to be wary with all the labs, because the patient becomes demoralized. Even after treatment, RPR dilution doesn't come down. So we have had lab errors, so we had to be aware of it. So what now CDC has introduced is, you should always start with a treponemal specific test and then move towards non-treponemal. So usually what we do is screening test with VDRL or RPR. If that is positive, you confirm with TPHA. But what is now changed policy in 2024 is you start with a treponemal test like TPHA, or they do FTA ABS and other specific tests. If that is positive only, then to know the titer and follow-up, they do the non-treponemal test. By doing that, you will remove most of the false positives. The thing is, TPHA may mean past infection, so you have to always proceed with RPR and then assess the titer, active infection, and then treat. And always RPR VDR is useful for follow-up, and a 4-fold reduction is expected. And again, another indication for CSF is non-responder. If they don't find a 4-fold increase, despite they have taken the treatment and they are following all precautions, if they have multiple partners, then also you have to suspect neurosyphilis, because neurosyphilis is present, then your VDRL titer will not come down even with benzathine treatment, benzathine penicillin, because it doesn't penetrate the CSF. So those are the indication where you have to consider CNS syphilis. Especially in HIV, you have to have a low threshold and no fall in titer by 4-fold. expected by 6 months to 12 months. So that is also important. And it is also important that you test the RPR titer or VDR titer on the day of penicillin injection. Why? Because you would have done the VDR test 2 weeks ago and the patient will come with a report. That 2-week titer may be actually lower than the day when you give the benzathine penicillin. So it is, then you will think, why is it not coming down? Because you would have had 1:64 2 weeks back. Now it may be 1:256. And then that is when you start the treatment. And after 6 months, you may look at and it may be 1:128. So these are confusion. So you have to do the RPR on the day of benzathine penicillin so that you are keeping track of the titer. And the last point is, in nowhere it is recommended or compelled to do either HIV, HCV, hepatitis B, that is bloodborne viruses or syphilis before any procedure. It is only standard precautions, but you can do because you may pick up more cases. But I mean, patient can ask, why do you want to do? Because it is not, it is not a mandatory test as of now, because you have to follow all the standard precautions. That is what, but it is a individual choice. Our hospital protocol can be made. Otherwise, there is no mandatory recommendation to do all this. You may pick up definitely more those cases, especially with visa medicals. We have who are migrating to Canada, New Zealand. We have got a lot of cases who are elderly and syphilis positive. And many have accepted that they have received penicillin or treated syphilis. Many doesn't know. So we know that there's a huge population and we are seeing only tip of iceberg. Okay, thank you.
Dr. Abhijit, anything more to add, Dr. Abhijit?
Hi, sir. In our hospital, we used to give this benzathine penicillin, that is Penidur. The thing is, our hospital is situated near to area named Perimbavur in Kerala. That is, most of the northeastern workers come over here and work, and we used to see many syphilis cases. That is, 2 weeks back only I saw a primary syphilis case, and we gave that too, he came with a transgender, and that transgender was not ready to get examined. And I asked him, we should do examination, but he was not ready. And only the syphilitic patient took the treatment. And as earlier said, we, according to NACO 2024 guidelines, we give crystalline penicillin only for neurosyphilis, while benzathine is given for early syphilis, which includes primary, secondary, and early latent syphilis. That is benzathine, 12 lakh units given on each buttocks. And we do a allergy, that is test dose, and we keep a RRT team. In case if anything happens, the rapid response team will manage the things. And secondly, for the late syphilis thing, which includes tertiary syphilis as well as the late latent syphilis, as earlier Pradeep sir told, we give 3 shots once weekly for 3 weeks. And we ask the patient to do the RPR after 4 weeks, then 6th month, 9th month, and 12th month, to see whether there is a 4-fold decrease in the titer or not. Then only we can tell that the patient has got adequate treatment. Or else, if we don't know whether the treatment failure has happened or not. Thirdly, this, as Pradeep sir told, every patient's concern is whether the TPHA will be negative or not. It won't be negative. It will be a permanent scar until lifetime. TPA will be positive lifetime. But if any reinfections have happened, then the VDRL again will be reactive. That is the thing. And as as Vinod sir told, there is a increasing trend of the syphilis. During my PG days and all, I have not seen that much syphilis. But now, recently, the trend has increasing. I've seen many cases.
So I think, especially the andrology group here, we have to start doing. Raghavendra, you have a comment to make, a short comment? You are muted. You are muted.
Good evening, Vinod.
Yeah.
Indal.
Vinod, can,
Yeah.
Vinod, can you hear me?
Yeah. We can hear you.
Dr. Vinod, can you hear me?
Yeah. We can hear you.
Actually, Pradeep sir and Rajashmi madam has cleared the doubt, but if RPR, we are doing RPR because PDRL reagent is not available. So if RPR negative and TPHA positive, the better we have to do is FTABS and Treponema pallidum particle agglutination test, but both are not available. In Vellore, they are doing FTABS research purpose, but not available in Kerala. But in early cases, we have to send for molecular diagnosis.
Okay.
Please be aware that there is something called syphilis PCR that is available. Hope that was discussed in the early session. I was not there. So it can be done from the lesions, or we have had a positive sample even from a throat swab for a MSM population. So PCR is good for any stage, especially if they have active lesions.
Okay. I will. Any comments? We will. Otherwise, we will move on to the next one. Yeah.
Just one comment, Dr.
Yeah.
Vinod.
Yeah.
See,
Yeah.
basically, one thing is you have to look for the ocular infections also. That is one thing we have to be very careful. We get mostly from the ophthalmology group with the chorioretinitis, where it will be treated as a neurosyphilis. I had 2-3 patients who presented with pure ocular lesions, and then we had to admit and give Benside. So that's another manifestation which we see.
Okay. Yeah, Raghavendra, with your comments, I think we will move
Yes,
to the
sir.
next.
There is one question. There is one infertile couple where husband has got asymptomatic syphilis positive. VDRL titer is they have done already. TPHA is also positive. In that patient, after 3 courses of treatment, VDRL dilution still it is positive only 1:2, and TPHA titer is also reducing. In that particular case, they have done TPHA titer beforehand. So I told him TPHA will be permanently positive, but he is looking at the titer. He is asking persistently for the titer should become negative. That is one. And second thing, VDRL is still persistently positive. So after the course, so he's an asymptomatic, just came for fertility. Routinely, they have done the test. In the test, this is the situation.
Yeah, this actually I mentioned, we have gotten entity known as zero fastness. That means even after adjuvant treatment, the VDL will not become non-cleared. 1 in 4, 1 in 2, 1 in 1 will be weakly positive, sometimes even throughout life. And nobody knows the exact reason, but there have been some reports in some journals saying that commensal spirochetes in our genitals could be the reason why this VDL is still persisting. You have to reassure the patient, but previously, I think somebody has mentioned that you look at the VDR, if it is not going down for a long time, no problem. But if the patient has got a reinfection or previously the last known titer was 1:4, the next sitting it is 160. There is 4-fold increase. You give retreat. Either he has got a reinfection or he is not telling the correct history.
Is
Otherwise,
there
it's
any
just
role for the TPHA titer, sir? Is there any role for TPHA titer in
TPHA
monitoring?
titer is not going to have any clinical implication. It will be positive throughout life. There is no actually any scientific rationale in the TPHA titer and the syphilis process. No.
Okay, so there is another dilemma, sir, in clinical situation where there is an exposure. How early we can diagnose, either with molecular test or VDRL RPRS screening, or it can be TPHA. Is it 2 weeks because the incubation period starts from 10 to 90 days?
90 days.
So how early we can diagnose this
Within
accurately?
2 weeks, we can do PCR test. I'll tell you the hierarchy. PCR becomes earliest positive. It is FTABS, VDR, TPHA, TPI. This is the range in how it becomes positive. PCR within 10 to 14 days become positive. The earliest test to become positive will be FTABS. But even earlier, we can do one thing, but it requires expertise. If the patient has got a frank lesion, for example, genital ulcer, the day one I can diagnose by doing a dark field microscopy.
Dark field microscopy. Thank you, sir.
I think now we will move on to the next topic of STI diagnosis. It will be discussed in a presentation by Dr. Shashikumari. And after that, we will discuss the questions on that particular topic as well as the purulent urethral discharge with negative cultures. Over to you, Dr. Shashikumari. You can share the screen.
Okay, yeah, I'll just share this. Is it okay?
Yeah, you can. Yeah, fine.
Sorry. So the topic is on actually how you're going to collect the samples for culture and what all panels. This was the topic given to me. And first we'll think of we'll just discuss about urethritis. When it comes to urethritis, it can be gonococcal or non-gonococcal. As you all know, you have a long list of organisms which can cause non-gonococcal urethritis like chlamydia trachomatis, ureaplasma, ureolyticum, mycoplasma genitalium, trichomonas vaginalis, and some viruses like herpes simplex virus and adenovirus. And there are some other species also which have some questionable role because they have been continuously isolated from the specimens, but actually they are commensals and a proven etiology is not there that they are pathogens. But even if they are present, it has to be alerted to the clinician. Now coming to urethritis, if the patient has got readily expressed discharge, then it can be taken with the help of a swab and a slide can be prepared for direct microscopy and then culture and NAT. These are the usual protocol for a discharge. Neisseria gonorrhea culture, what we prefer is you do a bedside inoculation onto chocolate agar or Tea Martin media, whatever selective media you want, you can use. Neisseria gonorrhea, if you're going to transport the pus to the laboratory, it will take a lot of time and there is every chance that the viability is lost and we give you a negative report. So culture, whenever you want a culture better, you alert the microbiologists. They will come to, even I have gone to bedside and done a bedside inoculation onto chocolate agar. We take the pus directly from the patient and inoculate onto the media. If it is not possible, you can use some transport media, which includes Amis media, Stewart's media. But you should never refrigerate a sample which is supposed to be sent for culture, because if you refrigerate, the viability of the organism will be lost. If you're transporting, you have to transport it immediately to the lab, even if it is in the transport media. Don't think that it will remain viable for days. So the viability is very, very, like it is a very fastidious organism which gets easily killed. So the best preferred method would be you call a microbiologist if it's available. And in just like tertiary care centers and all microbiology department we go to the bedside and inoculate it directly. And if you're not used, like there is another choice also, instead of using a swab, you can directly take the pus. If it is actually a readily expressed discharge, you can take the pus itself with the help of a platinum loop or nichrome wire, whatever is there in the microbiology department. And we can streak it onto the plate and we can prepare a slide also from this. So this is regarding a readily expressed discharge when it is present in a case of urethritis. If visible discharge is not there, then you have to think of taking a endourethral swab. For that, you have to put the patient in the supine position, and ideally you have to restrict fluid intake the previous day and collect the sample early morning before passing urine. This helps to recover even small quantities of urethral discharge. Suppose that he's coming on the midday or evening, you always advise you have to take the endourethral swab, that is 2 hours after his last micturition. Only then you can get some organism or pus cells in this particular swab. That is the endourethral swab. So when you're taking urethral swab, you have to insert it 2 to 4 centimeter into the urethra, rotate gently and take it out immediately. We should never use a cotton swab because cotton has got an inhibitory action on gonococci, as well as when you're sending it for some Actually, even in NAT, you don't get sufficient material if you're taking it in cotton swab. The whole thing gets absorbed onto the swab. So ideally, we would prefer Dacron or rayon swab. And it can be used for microscopic, this swab itself can be used for microscopic slide preparation and for bedside inoculation on culture media. If it is not possible, with transport media, you can send it to the laboratory. Again, do not refrigerate if you're thinking of a culture. When you're taking a swab, when you're taking a slide, that is, you're making a slide for microscopic examination, never rub the swab on the slide. You have to roll it gently and you have to air dry and avoid heat drying. So when the urologist or any medical personnel, if they are taking this urethral swab, they should not be rubbing it on the slide. Just roll it gently on the slide, and that's so that the material is present in a small layer, and then avoid heating the slide for drying it. And another choice is that you can use the initial 10 ml of the first voided urine, which can be collected for wet film as well as for all other investigations. So when do you call it urethritis? You can call it urethritis when the gram stain, you have taken the slide, now you're doing the gram stain, and when it has got more than 4 pulses per oil immersion field, or when you're taking the wet film of the first voided urine, if it has got more than 10 to 15 pulses per hyper field, you can call it urethritis. Okay, but here sometimes, you don't have the wet film examination facilities. You can even do a leukocyte esterase test, which actually shows the presence of WBCs. So with these two tests, which is a protocol, you have actually found out that it is urethritis. But this urethritis need not be always a sexually transmitted infection. It can be even a part of urinary tract infection, initially urethritis, cystitis, and the patient may be having dysuria because of urinary tract infection. So it would be better that you always send a routine urine culture also for such patients, so that you rule out the urethritis which is caused due to urinary tract infection and it is not a sexually transmitted infection. So for the urinary tract infection diagnosis, you have to send a midstream urine sample. So you do a routine culture of urine, and then you can actually rule out other causes of like urinary tract infection. Now, even non-infective urethritis can give positive results. So always a clinical correlation history, everything is important. So with the gram stain and the wet film of the first voided urine, now you have found out that it is urethritis. Now you want to know whether it is gonococcal or non-gonococcal. So that you have to take the slide which you have prepared, do the gram staining, and then you look for the smear. You can see a lot of pustules are there. But inside the pustules, you have the typical diplococci, which is never missed by a microbiologist. Very easy to find if you have that copious pus discharge. Okay. And then these diplococci, 95% of cases of Neisseria gonorrhoeae, we will see the diplococci, but sometimes we may miss some cases which has to be caught up with other investigations. Now, typical intracellular gram-negative diplococci. Suppose you're seeing some gram-positive cocci or some gram-negative bacilli which is coming up at the smear, you need not be concerned at all, because you're going to look for only gonococci, and which is actually the concern for you right now, because the other tests you have done a urinary tract infection test, and now you're bothered only about the sexually transmitted infection. All this can be a normal flora present in the urethra, that is a gram-positive cocci and the gram-negative bacilli, which occasionally come up in the smear. Now, if there is no diplococci, you call it non-gonococcal urethritis. But every chance is there that you miss it, because 5% is there here. And sometimes if the bacterial load is not very high, as in the case of, say, a very scanty discharge, maybe you will miss it. So you have to go for other tests. Both actually NACO and other CDC, they all insist that you don't take it as a pure case of gonococcal infection, because always you may have a co-infection with other non-gonococcal urethritis agents also. So always when you treat better, you have a syndromic approach. You treat this plus you give additional doses for the non-gonococcal urethritis coverage also. A patient who has got the risk of getting gonococci will have an equal risk of getting other agents also. So you have to better cover this. That is a syndromic approach, which is actually advised by NACO as well as CDC. Now, wet film examination you can do. Suppose you are suspecting Trichomonas vaginalis. Actually, it is simply treated by a dose of single dose of metrorel or indosol. But suppose you really want a laboratory diagnosis of Trichomonas vaginalis, one way is you can make a wet film. That is, you take the endourethral swab, put a bit of saline, and make a wet mount. Or you can take the sediment of the first voided urine and then you can look under the microscope as a wet film and you will see the motile trophozoites which can be appreciated by a microbiologist and they can give you a diagnosis. If you get it positive, well and good, it is 100% positive. But a very low sensitivity, you may trace and find out only some 30% of the cases. Once they become non-motile, they look almost like epithelial cells and it is impossible to find them. And this motility is also lost very fast. So you cannot actually rely on it. It is very, sensitivity is very low, but once you get it, it is 100% specific. You're sure that it is Trichomonas vaginalis. Next comes culture. When it comes to the culture of these organisms causing urethritis, we should know that majority of the organisms are not culturable. In the routine practice, if you have that's all the sophisticated laboratory setup, you can do the culture. Otherwise, what you can culture is Neisseria gonorrhea. As I said earlier, a bedside culture is better. It's a fastidious organism. Once you get it, you're 100% specific because it is not going to be a contaminant which has come in the lab. It is a true pathogen. So if you're getting it in your culture, well and good, it is 100% specific. You can use modified Thayer Martin media. You can use Martin Lewis media or chocolate agar. All this can be used for culturing Neisseria gonorrhea. We insist on a culture and we really try for it, especially when a case of gonorrhea is not actually completely cured after treatment. Then you have to think of an antibiotic resistance. And if you want to test the antibiotic sensitivity, you have to do a culture and get it. So that is one indication where you really have to do a culture and somehow isolate the organism to test the antibiotic sensitivity. The non-gonococcal agents, majority of them are not easily culturable, not easily culturable. You need some cell lines and all sophisticated equipments. Now coming to the endocervical lab and sediment of first voided urine, I said we can look at the wet film for Trichomonas vaginalis. But if you just put it into a liquid medium called modified Diamond's liquid media, you can culture it. Culture is possible. Again, this culture series of, say, you have to take wet film every day and see whether this organism has thrived in it. If you miss it, okay, you're going to miss it. But if you find it, okay, 100% it is Trichomonas vaginalis. Here, the probability of getting all these things in culture is almost very, very, say, negligible. You don't get it very easily. As far as microbiologists are concerned, this is actually a big task for us trying to culture Neisseria gonorrhoeae and Trichomonas vaginalis. So culture is not a very reliable and a easy test. It is reliable, but it is not very easy to do. Okay. Now, sometimes when you send your urethral swab for culture, you get a lot of organisms like say E. coli or any other organism. You have to think of the normal flora or the agents causing UTI which has colonized in the urethra. So you need not be concerned about all those organisms. Sometimes you get Staphylococcus aureus or Staphylococcus, some epidermidis which can be sometimes colonizing the perineal region and it might have come in the culture. So that is not of much concern when you're focusing on Neisseria gonorrhoeae or non-gonococcal agents. Okay. NAT and or PCR, multiplex PCR, actually this is the gold standard for all urethritis agents. So you take the urethral swab, but when you're sending for NAT, you should not be leaving it in normal temperature. That is a room temperature. You have to refrigerate it. The cold chain has to be maintained. The urethral swab, again, you have to insert 2 to 4 centimeters in the urethra, just rotate it, take it out. Immediately, you have to put it in the viral transport media or the universal transport media, whatever is supplied by the company or the agents who are taking it. Initial 10 ml of the first voided urine can also yield the organism. This is actually very high sensitivity and high specificity. So even those cases of gonococci which you miss in your microscopy or in culture, you can catch in NAT or PCR. This would be the preferred test for urethritis when we are actually capable of doing it. Otherwise, you have to rely on other tests like direct microscopy. Here, the cold chain has to be maintained because, as you all know, nucleic acids easily get disintegrated if they're kept in the room temperature and you send for NAT, which is a very costly procedure, and finally you get a result which is negative, maybe because your method of collection and transport was not correct. So you have to be very careful when you're collecting the samples for NAT. Different panels are available for all agents of urethritis like non-gonococcal and gonococcal urethritis, very highly sensitive and specific. Of course, sometimes you get a false positive test. This is especially in treated cases due to the dead organisms. So when you're taking the endourethral swabs, what happens is some dead organisms may be there inside, the DNA is there, and this DNA is being amplified and it has been taken as positive by the machine. So this can happen once in a while. Otherwise, this is a very highly sensitive and specific test. Now, recurrence of urethral discharge, again, like I said earlier, it could be something like gonococcal infection along with a non-gonococcal urethritis agent. So you missed it, you treated only gonococcal, then you have recurrence coming up, which may be a second urethritis may be due to a non-gonococcal agent, which was actually thriving in the urethra along with gonococci. So a syndromic approach is always advised, and drug resistance in gonococci is another possibility why you got a recurrence, especially of gonococcal infection. You have to test for the antibiotic sensitivity. Coming to prostatitis, it can be acute bacterial prostatitis where you have a lower urinary tract infection and sepsis. As patient is very sick, toxic with all the changes in the blood. And chronic bacterial prostatitis where recurrent UTI with the same bacterial clade is there and the patient is not having sepsis or any such features usually. Then you have the CP, CPPCS, all that syndrome and things which actually 90% of people, there is no particular pathogen to be isolated, but they have chronic prostatitis. So this is actually one field where like you don't have any organism and the patient has got prostatitis. Now, acute bacterial prostatitis, you have to take the midstream urine sample and send for bacterial culture. So that will be positive in bacterial prostatitis. But here, what we are looking for is mainly the enteric pathogens, which can cause urinary tract infection, the Enterobacteriaceae, which includes all those E. coli, Klebsiella, Proteus, and all those organisms, and even Enterococci is there, which is an enteric organism. So all this can cause infection, urinary infection, and here the midstream urine is being sent for culture. And the patient will have systemic illness. You have to send the blood culture sample also, and it should actually correlate also, especially if it is urosepsis, the organism which you got in urine should be same as the organism you get in blood if the culture is positive. Then urethritis agents in young people, you have to look for some STI, sexually transmitted infection causing urethritis can cause bacterial prostatitis also. So it's in young people, or if you have a clinical suspicion, you have to screen for the agents of urethritis also. Again, that here the NAT test will be preferable, NAT or PCR, whatever is available. Then chronic bacterial prostatitis, you have to, the patient gives a history of recurrent UTI, and this recurrent UTI is almost always with the same bacteria. There is no systemic illness. Again, you have to take the history and think of other STI agents also like urethritis agents and screen for that also. Then chronic bacterial prostatitis, we can take extra samples like for which we actually don't take for acute prostatitis. Chronic, we can think of an express prostatic secretion as well as we can think of a semen culture. Okay, then you have the technique called 4-glass test where you have to take the first 5 to 10 ml of urinary stream that is called VB1, and then you have to take the midstream sample which is called VB2, and then express prostatic secretion EPS, that is up by digital massage, and then voided urine, that is immediately after massage you take the voided urine, that is called VB3, that is the first 5 to 10 ml of urinary stream immediately after the massage. So these 4 samples can be compared for. This is actually, it was considered as a gold standard in for chronic bacterial prostatitis. And in chronic bacterial prostatitis, the bacterial count in the EPS and or VB3 specimens will be at least 10-fold higher than the VB1 and VB2 samples. That is, a count is very important here. Bacterial count, you have to insist on the count. Otherwise, we just give the report as significant bacteriuria. You have to ask for a count for all these samples. Only then you can take a decision regarding this 4-glass test. Then in chronic bacterial prostatitis, you can do an extra test, that is semen analysis. It is not a test which can be interpreted in isolation. You have to do it just as a complementary test. Along with other tests, you can do this and okay, confirm it. So if there are more than 10 leukocytes per, that is 10 pus per hyperfield, you think of chronic prostatitis. The culture yields uropathogen where count more than VB1 and VB2 will be there in this prostatic. You have to think of a prostatic source when the count is more than VB1 and VB2. And NAT, PCR, etc. can be done if you think of a STI causing this prostatitis, that is chronic prostatitis. And here, if you're getting a mixed bacterial growth from the microbiologist, you can simply ignore it because it is a contamination which has happened with the normal flora which is present in the perineum or in the urethra because of some improper method of collection. All these things can happen and you can get a mixed bacterial growth. So if leukocytes are more than 10 per hyperfield, but no organisms are there, then you have to think of CP-CPBS. That is regarding semen analysis. So semen is also a ideal fluid which can be cultured for chronic prostatitis. So here, 90% of the cases of chronic prostatitis, you're not getting any bacteria. Sometimes the culture may be sterile and leukocytes will be present, and it will be these leukocytes will be present in VB3, semen. All these counts will be some kind of inflammatory reactions are taking place, but sometimes you don't get an isolate. Urine culture, when you're doing in bacterial prostatitis, as I told you earlier, it is always the uropathogens that come up, and extra what is coming up is Pseudomonas also, which is also significant here. But if you're getting Staphylococcus aureus in your culture, that surely means there is some upper UTI, okay? You have to think of some septic focus, and you don't have to believe it 100%. You can ask for a repeat culture. And sometimes, patients, not patients, even normal people, we 30% of us are carriers of Staphylococcus aureus. We may have it in the perineal flora, and this can come up when you're catching the urine sample. It may be there in the urethra also. So this you don't have to rely unless you have a history of some septic focus somewhere in the body which is causing an upper UTI. Otherwise, always the organisms are Enterobacteriaceae, especially E. coli, which is a major Enterobacteriaceae encountered in urinary tract infection. And even Enterococci is actually an enteric pathogen which can come into the urinary tract. Pseudomonas, in some special conditions, they do come up in the urine culture of prostatic patient prostatitis. Now, the STI causing prostatitis, like urethritis agents, all these organisms can cause prostatitis. But usual cases, what we find the common findings are chlamydia and gonorrhea. They are actually responsible for causing prostatitis. But any organism causing urethritis can enter the prostate and cause infection. Now, next is all those genital ulcers of the mucus, all the other sexually transmitted infections. Actually, we don't have much of any wonder investigations for all these things. Majority of these organisms, you have to rely on NAT or PCR. Otherwise, you have, say, for herpes, this I have written with a different color because I want to discuss it separately. But I think major part of the discussion has already come up in the last class. So if you take up all these things, herpes simplex virus, direct microscopy, if you want, you can do a sang smear or all those things. All it's actually varies from person to person. And one microbiologist may not be competent to find it, another person may find it. So much of variations can happen if you're going to rely on the sang smear. Otherwise, these multinucleated giant cells which are seen in the sang smear is actually confirm. We can actually say it is almost herpes simplex itself. But now we have so many good nucleic acid amplification tests. We better prefer that. Even for Haemophilus ducrei, direct microscopy was once upon a time used where you get that school of fish appearance and all that. But now you have NAT on which you can rely, lymphogranuloma. All these are tests which can be best diagnosed by nucleic acid amplification. And then comes syphilis. Syphilis, we have already discussed it earlier. Sir has discussed it. We had direct microscopy once upon a time, but actually you have so many other common cells, spirochetes also coming up in this dark field microscopy. So it is not 100% reliable. It can be Strychnema pallidum or it can be some other common cell. Then you have the silver stains. Again, there is a chance of common cells coming up. Then you have the test, serological test, that is a non-treponemal test and the treponemal test. In non-treponemal test, that is when it is actually used as a screening test. It is not a confirmatory test. You can get VDRL positive, or actually in government setup, we are doing only RPR because this is a very cumbersome procedure. You have sometimes mostly the reagents are not available, and preparing the whole thing itself is a very cumbersome procedure. Now we are almost not doing VDRL. We are actually relying on RPR only, which is somewhat equally sensitive. And these are just screening tests. Once they become positive, you have to confirm with the treponemal test, that is TPHA, that is treponema pallidum hemagglutination test, or the particle agglutination, and FTABS. This is again a very, say, a test which cannot be done by all the institutions because you need specialized immunofluorescent microscope for that. And as Dr. Jyoti said earlier, it is available only in CMC and such institutions. But it is actually a confirmatory test. You have TPHA and TPPA, which is confirmatory. But as the discussion, as we had already discussed, sorry, these are tests which will remain positive lifelong. So if you're doing VDRL, RPR, these are actually prognostic markers also. Once you start the treatment, the titer comes down, you can be happy that, okay, your treatment is being effective, the VDRL and RPR titers are coming down. So this is a prognostic marker also, and once the patient is cured of the disease, it becomes negative, whereas these two tests will remain, the treponemal test will remain positive lifelong. And one thing that has to be remembered is that VDRL test positive is actually detecting only the cardiolipin antigen, which is actually some, say, antigens released by the body in response to the infection. That is, it is a human antigen which is released. It is not the pathogen antigen. Okay, it is not the antigen of the say organism. It is actually some antigen which is released by the body due to the infection. So this can happen in chronic cases of tuberculosis, malaria, all autoimmune diseases, and n number of other cases can show VDRL positivity. So that doesn't mean that it is, and it is not a wonder test that is going to tell you that this is syphilis. Okay, you're not going to just decide that this is syphilis by doing a VDRL or an RPR. This can happen. False positives, biological false positives can occur in so many chronic infections. And once you find it positive, you have to go for the confirmatory test, and only then you can say they are actually, it's a case of syphilis. But if you have an active lesion, as urologists may come across some kind of lesion in the genitalia, you can always go for a PCR, which is available almost in all, say, major laboratories, where PCR will be confirmatory. The lesion you can take from that site itself, you can take the secretions and go for a PCR. So I'll just conclude like this, in a chart, just to say sum up the whole thing. That is, if it is a case of urethritis, discharge may be present. If it is not present, you can go for an endourethral swab and the first voided urine. So all this can be taken for microscopy to decide whether it is urethritis due to gonorrhea or other organisms. But best test or the recommended test will be NAT or PCR for these, or for all agents of urethritis, because other tests are anyway, somehow or the other, you're going to miss it, because even gonorrhea is not culturable. You may miss it in the microscopy. Everything can be caught in a NAT or PCR test. When it comes to acute prostatitis, you are concerned about the midstream urine sample and blood sample if you're suspecting sepsis. Again, the endourethral swab, FV, the first voided urine, if you're thinking of STI, send it for NAT, whereas these midstream and blood, you can send for culture. When it comes to chronic prostatitis, the 4-glass test, as I told you earlier, the expressed prostatic secretion or semen, you can send for culture. And here you're concerned about the uropathogens, you're not concerned about the STI. But if you are thinking that there is an causative agent like something causing urethritis, you can again send it for NAT. Coming to syphilis, you will think of taking serum sample, and you will do VDRL or RPR as a say primary investigation, just to screen whether it is positive. Once it is screened, you can think of doing a confirmatory test. But as ma'am said earlier, see, now it has reversed. Now better do TPHA. If it is positive, you treat the patient as a prognostic marker. You can do VDRL and RPR. So all these cases, there is every chance that they can get other infections also. But if, according to the NACO guidelines, they say that you have to do. It's not, you cannot say it is mandatory, but you have to take the consent of the patient, do maximum counseling, and you have to do tests like HIV, hepatitis B and C for all those people who have the history of other, say, sexually transmitted infections. These tests are easily available in the ICTZ, all those antigen antibody based ELISA, CAR test, everything is easily available. So we should actually take some effort to screen for these diseases also, because it is actually anyway through the same route they're getting the infection. So you should actually rule out these infections. Then comes the herpes simplex, hepatitis, sorry, HPV virus, all this you can take. Again, PCR will be the ideal test by taking the swabs from the source or lesions. You can send it for PCR. But as Sir has said, experts are there who can simply diagnose these warts without any test. So actually, if it is if you find it may support your diagnosis, you can send. Otherwise, there is no meaning in sending it. Even the herpes simplex lesions, it is actually the experts can simply find it easily by looking at the lesions itself. Now coming to asymptomatic infections. Okay, the patient does not have any symptoms, but you're seeing all those pustules and things when you're doing your routine investigation, as I said earlier. So you're looking for all those things. You're finding pustules more than four in the case of, say, the discharge, and you're finding more than 10 pustules, 10 to 15 pustules in the urine sample. Now you know it is urethritis, but the patient does not have any symptoms. He is fine. So all these things, your only way out is go for a multiplex PCR, where you have a series of organisms which can be diagnosed by a single PCR. So that's regarding the common, say, sexually transmitted infections which you can diagnose in the laboratory. Then you have so many other sophisticated investigations. This is actually the routine thing which is done, especially in tertiary care centers like Medical College Trivandrum. So Vinod, you want some discussion?
Yeah. Thank you. Thank you, Sister Kumari.
Welcome.
Can you stop sharing it so that?
Okay, sure.
So I think Dr. Sushumari has completely covered all our questions regarding this. These are the questions we initially had for the discussion on STI. Now, about ureaplasma and mycoplasma, is it the same NAT test or the PCR panels we are using?
Yeah, only PCR panels can detect it because they are not easily culturable. Not easily, it's very difficult to culture these organisms. You have some cell lines also, even there you cannot get it without contamination. So it's actually a very tedious procedure and may take time also. So better go for NAT. NAT is actually very specific and sensitive, and you have that facility almost everywhere. You have agents from the lab coming with the cold chain materials. They come and collect it and they take it. It's all very comfortable right now. You don't have to actually send the patient anywhere. You can call the agents, they come and take this, they collect the swab and then they maintain the cold chain also, and they take it to the laboratory and send you the result via email also. Everything is handy. So better go for NAT only, because NAT is very highly specific and sensitive.
So for a prostatitis patient, suppose we have multiple exposure history and we are suspecting something inside his prostate. Is it better we do a prostatic secretion, or taking a semen as a sample, or a urethral swab is sufficient in such cases?
See, urethral swab, as I told you earlier, it's mainly for sexually transmitted infections. I mean, urethritis due to sexually transmitted infection. Whereas if you're suspecting urinary tract infection as the cause for, which is usually the cause for prostatitis, you have to go for a urine culture, that is the midstream urine culture itself. If you're taking chronic prostatitis, when you're getting recurrent infection of the same organism, you want to know whether that same organism is there in prostate, then you have to express and take the specimen, because that should show a tenfold increase in, not tenfold, it should show a large number of organisms compared to the VB1 and 2. Only then you can say, okay, prostatic organisms are there, which is causing prostatitis. Then semen is not a test which you can rely on by just doing semen. You have to do it along with other tests. Only then you can just say strengthen your diagnosis. Otherwise, semen alone is not a reliable test. You can strengthen it with other tests like EPS and other VB1, VB2. That is a gold standard. They say, earlier also it was considered very reliable.
So the tenfold means suppose you are getting in VB1 and VB2, you are getting 1,000, and then in the other one you are getting 10. Is it a tenfold rise?
No, tenfold rise means, in VB1 you don't get, and VB2, that is especially when you have a midstream urine infection, you will get some organism. If it is some 1,000 per cubic millimeter, then it will be just one colony in our plates. One colony is equivalent to 1,000 organisms CFU in 1 milliliter. So we get only one colony. But if you get 10 colonies in the expressed specimen, then you call it tenfold increase. So it is very important that you ask for the number of bacterial colonies when you have such doubts and you want to relate it, then you have to ask for the CFU. CFU is the colony forming unit. Always people ask how many CFUs are there. So they are actually interested in the count because they want to make this comparison.
So when you are requesting
Can
for
I add a word, Vinod, with your
Yes, sir.
permission, Mano's permission?
Yeah.
I think Vinod pointed to the pertinent problem. In case of chronic prostatitis, very commonly we use the term complicated urethritis when gonorrhea and chlamydia affects the prostate. Unfortunately, most of the first-line drugs won't penetrate into the prostate. Now, for a diagnosis, madam has said that you can take Euthyrox, etc. Sometimes, in a chronic recurrent prostatitis, we do a prostatic massage for the material to send for culture or for grafts. Very often, we are found to be positive. We can do a prostatic massage also.
That I had mentioned about it, sir, that EPS sample that is taken by prostatic massage only, and the count should be more than VB1 and VB2.
So in such patients, we need to ask for the colony forming, the colony count rather than the whether it is significant or non-significant.
Yes, that is very important because, like usually when we get some 2 or 3 colonies in a routine urine culture, we simply report it as no significant bacteria. We call it significant only when we get more than 100 colonies. So if you're not asking for it, we will simply report it as no significant bacteria. But here for you, even one colony is significant because you want to compare it with the EPS. So when you're sending for such culture, you have to ask about the number of colony forming units to the microbiologist, otherwise you will miss it.
Dr. Karthika, what you are offering to our patients in your lab? Dr. Karthika, are you online?
Yes, sir.
Yeah.
Sir, Shashi Kumar, good evening once everyone. Shashi Kumari madam has already covered everything. As a microbiologist, what we usually encounter problems is that even with a microscopy, we have some problems challenging because most of the organisms like chlamydia trachomatis, like mycoplasma, genitalium, they won't take the stain, usual things, because they lack the cell wall. So we may miss it, giving a false diagnosis. So that is why the gold standard is being mentioned as the NAT or the PCR. Yes, we do have in DDRC, we have different panels for STD panels are available. Even you can choose which all panels you can take. Even for chlamydia trachomatis alone, we have ELISA methods are there. For herpes simplex virus also, other than the PCR herpes simplex virus, we have ELISA methods as well as the CLIA methods we are doing. And other than that, almost she has already mentioned everything. And some other problems is that the quality of the smear is also highly dependent of the sample is taken. In the case of an asymptomatic patients, the sample will be less, or they have no symptoms, will be scanty discharge. So it will be difficult to obtain a good sample for a microscopy. So in that case, the gram stain will have a lower sensitivity in the case of the asymptomatic persons. in that case also the NAT or the PCR plays a major role as a gold standard for the diagnosis.
So how do you manage it for suppose we have a patient in a outside center? How do you do it? You send a cold chain a person with the cold chain facility, or you visit,
Yeah,
or
you have different types of, you can have genital swabs. We have different panels, sir. So you can have a genital swabs or you can send the urine samples. Whichever it is possible, we can take it. And we have this temperature that is cold chain maintained. The maintenance is there. And which is frozen, it can be taken as a frozen samples also. We have different ambient temperatures are maintained, sir.
Dr. Raghavendra, you had some points?
Yes, sir. So we treat patients with chronic bacterial prostatitis, especially semen culture is positive while we're evaluating for the infertility. We'll treat for 6 weeks. After 6 weeks, initially they'll come with E. coli, next they'll come with Pseudomonas. If I go give a second dose based on the second culture, after that he'll come with a different organism after 6 weeks. So what is the background? This because patient is asymptomatic. We are treating asymptomatic positive because we are evaluating for infertility. Where semen is also showing pus cells, culture is positive and culture is persistently positive after antibiotic therapy, which is of reasonably sufficient duration, with different organisms coming at different reports.
See, there's
So,
different
yes,
Can
ma'am.
I? Can I? So
Yeah.
first thing is like when you get, suppose you got E. coli from the first sample, you have to treat it completely. And then after a gap, he's getting some other uropathogen. Then actually it is not matching with the chronic prostatitis definition. I don't know how far it is correct with the theoretical knowledge we have. But you have more of practical knowledge. Chronic prostatitis means usually we get infection with the same kind of organism, same enterobacteriaceae. And Pseudomonas, as you said, is not an enterobacteriaceae, but it comes occasionally as a colonizer. Colonizer means actually they are not uropathogens, but they somehow get into because of some, say, surgical manipulation usually, or some urethral, say, normal anatomy is altered. Then you have organisms like Acinetto or Pseudomonas. All these organisms can colonize. And when they colonize, sometimes when the immunity of the patient is lower, they can become a pathogen also and enter the prostate and cause prostatitis. Otherwise, it is always the same clade. Clade means enterobacteria, the whole enterobacteria, which can include a huge family of so many organisms. But E. coli is the major thing. Okay, and so enterobacteria, what you said, they are all enterobacteria. Only you have to be you have to give concern when it is not an enterobacteria. What you said about Klebsiella, E. coli, they are all enterobacteria only, which can cause prostatitis. That is the same clade of organism. Whereas if you are getting Pseudomonas, you have to get concerned because there is some uropathology, some kind of anatomical disorder inside where this colonization is happening. Similarly, as I told you, if you're getting Staphylococcus aureus, you have to be concerned because it is not a uropathogen. So how did it enter the prostate? Is there any other septic foci? Okay, that from that focus it is coming and getting lodged into the prostate. So you have to search for that other focus in the body, any other infective focus. So Staphylococcus aureus, similarly epidermidis you're getting, it is a normal flora. So you have to take a decision depending upon what see, if you're giving a sample, the microbiologist will report what they got. But you have to clinically correlate. You have
So
to
if
see
you are,
that whether it is
yeah,
an
if you,
enterobacteria or something else. But
is
we
it
can't give a sterile report, no? So we will be giving you and we'll just ask you clinically you correlate because we don't know the actual history.
without any urological intervention or any instrumentation or a catheterization, is it common to have a Pseudomonas in?
Pseudomonas is very, very uncommon. Very, very uncommon.
Is
But
there
we
any chance?
have cases.
Yeah.
We
Is there any
have
chance of
cases. So
contamination? Is there any chance of contamination?
yes, every chance of contamination is also there. And whenever we get Pseudomonas, we actually ask for a repeat sample. We don't straight away report it as a pathogen. Because even in hospital environment, it is a organism which is very commonly found, just like Acinetobacter. All these are actually not primary pathogens. They just come up and they become opportunistic pathogens. So we have to be very sure. So that usually we ask for a repeat sample so that if the first sample is contaminated, in the second one we won't get Pseudomonas. We are not going to be very happy with Pseudomonas or Staphylococcus aureus coming in the semen or urine sample. Unless you have some abscess in the prostate and all, you can think of other organs.
So, is there any current role for serology like IgG and IgM in case of HSV?
Yes, sir.
Ma'am, you're giving the?
Dr. Karthika?
Yes, sir. For HSV, ELISA methods are available, sir. Herpes simplex virus for IgG and IgM are available.
But it can be used not for active infection, only if your actually patient doesn't have, if you want to screen for the partner, then you can.
Yes.
Not for treatment.
Okay, patient is asymptomatic. IgM is positive, and IgG is also is negative, or it may be both are positive. We'll consider it as an asymptomatic infection in that individual HSV. There are no lesions clinically, but IgM and IgG both are positive. He has got exposure previously.
Okay.
Currently, no lesions.
Yeah, patient can be asymptomatic and still can shed. And this may, if he has a positive exposure, then it may be suggestive of a recent infection without active lesions. And without active lesions also, if they are secreting in their genital secretion, they can still transmit. So they may need treatment.
So as I told you earlier, it is always better to confirm with a NAT, which is actually now available in your fingertips. You can you can be very thorough about the diagnosis, because every chance that you miss a diagnosis just because you're not doing a NAT. So if you do it, it's a very highly sensitive and specific test, so you can do it.
And it is multiplex. So that one is multiplex. So if the patient has multiple sexual exposure, then in one go you are actually picking up so many pathogens. So it is not for each pathogen you are doing the test. So it's worth doing a PCR, the NAT-based PCR, which includes chlamydia, mycoplasma, ureaplasma, and also the gonococci and many other STIs that we usually miss.
Yeah, we have multiplex PCR, multiplexing means all these antigens, all these genes are detected simultaneously. So with a single test itself, we can detect so many organisms.
So in multiplex PCR, are we going to detect these even protozoal organisms and fungal?
No. Yeah, Trichomonas vaginalis, you have a NAT test. Trichomonas vaginalis, it is there. But fungus, we can do a culture. All these fungi are culturable. Whatever fungi can come in the genitalia, like you have mostly candida, it's easily culturable. Next day itself, you can get the result. So you don't have to spend costly, unless you want to find out, okay, whether it is any particular species. For example, Candida auris is now is of great concern. If you want to find that, you can go for some automated things like Vitek or Malditov. So you don't have to go for a PCR for Candida. That is fungal culture. Usually it's only Candida that is coming up in the urine samples. You don't have any filamentous fungi coming up. But of course, as part of some systemic fungal, that is endemic mycosis like histoplasma, coccidioids, you can get the prostate also getting infected as part of the systemic infection. In such cases, if you want, you can do, but there is no need for a prostatic secretion to be screened for that. Even otherwise, with the other lesions, we can find out that the person has got a systemic endemic mycosis.
So, is there any role for this multiplex PCR in asymptomatic patients where they want to screen because previous exposure is there? They're going ahead with multiplex PCR. Is it the urine sample or it is the blood sample, or both we have to do? Anyway, we are
As I
sending
told
urine
you,
now.
I think maybe you didn't notice in that chart I had showed, last, that asymptomatic patients, you have to do a multiplex PCR. For that, again, that cervical swab, that is an endocervical swab, as well as the first voided urine they are the best samples. Blood does not have much role there. You have to send these only when you're going to screen for STI.
And in the
Specifically, you told it is 2 to 4 centimeters. When we put swab into the urethra, even just 1 centimeter, patient feels discomfort. It is not easy for us to insert up
See,
to 4
this is
centimeters.
just the ideal method. When we say the ideal BP is 120, 80, 130, 80 is not abnormal. So like if you can, you have to go that high. Why? Because first swab you take for microscopy, the organism is completely taken up. So initially you put about 2 centimeter, you take the swab. Next again, if you put only 2 centimeter, your material will be very less. When you send for multiplex PCR, you won't get enough material. So when you're putting the swab for the second time, you have to go a little higher. You have to go at least 3 centimeter and take a swab. When you're putting it for the third time for some other investigation, you have to go further high up to 4 centimeter because we want that material. Otherwise, you have to plan it on different days. If you cannot insert it in and get all these swabs at a stretch, you have to take, suppose you're trying to get it and you're able to insert only 2 centimeters. Okay, you take it for one investigation. Next day, again, you ask the patient to come. That will be very difficult. You may lose the follow-up. Patient won't come every day for taking swabs. So we give a range of 2 to 4 centimeters for different level. First level you take, second level you take. You can go maximum to 4 centimeters. That is what is meant by 2 to 4 centimeters. Otherwise, no hard and fast rule. And if you really are sending for NAT, you have to take a very good swab. Otherwise, you will get a false negative test. You won't reach the organism. The CT values may go very high, and then mostly the technician who is dealing with it may give a negative report. You'll get a false negative. Your sample is very, very important. You have to take a very good sample. Only then you will get a NAT positivity. Otherwise, you will miss the cases.
But in majority of the patients, when we are doing prostatic massage or expressive prostatic secretions, it is very hard to collect that sample. So any tips for that, Vinod sir? It is not easy to take that expressive prostatic secretion after even after massage.
Express prostatic secretion is little bit difficult. I don't know whether Vineet has a different experience on that. But what I relay is if at all I'm not getting it, I will go to the next urine sample, which may have this prostatic secretion coming up.
Yeah, that is equally
Yeah.
good. VB3 is equally good.
Yeah.
Actually,
After the
correct.
massage,
Yeah.
you take the third sample.
Yeah, usually it ends up being VB3. I think you don't have to stress yourself on making sure that you've pressed the prostate hard enough to get something out of it. The VB3 will settle it.
Yeah, most of the times we'll end up with VB3. Secretions we're not getting such easy.
So VB3 has to be taken after massaging only. But
Yes.
yeah.
And one concern to both our infectious disease consultants, Dr. Rajalakshmi and Dr. Sharik. See, when the description of culture methods for gonococcal is explained, what I usually feel is we have a lot of patients with purulent discharge, and most of us are not doing it properly, the culture samples and other things. And we just send to the lab and it comes as negative. And I believe that there is an equal number of patients who are taking over-the-counter medications for with antibiotics, and they're getting halfly treated. So, do you think that there is a possibility of a lot of untreated or undertreated gonococcal urethritis happening nowadays?
Very much likely, and especially because many self-treat with azithromycin and so, and now with a lot of drug resistance emerging, we are facing a lot of problem with gonococcal drug resistance. Even failure to ceftriaxone has been reported. So it's are partially treated or incompletely treated, and they come back again. I have some patients who come back with recurrent symptoms. Though he denies repeated sexual exposure, probably he is taking multiple over-the-counter prescriptions. So there are people who self-treat, and we are missing diagnosis, and we may not be culturing most often and in the right way. So we definitely it's highly possible that we are missing. But what is the beauty of the PCR is, if you do the PCR, definitely the yield is definitely better than culture, especially for gonococcus, chlamydia, which are difficult. Especially chlamydia will never grow. So I think we should, for any urethritis, especially in a sexually active man with multiple sex partners or MSM, we should carefully ask for the history and go ahead with the STI PCR. Urethral sample is easy to take. It is not difficult. The yield is good. I have been now experienced our yield is very good. So I think that should be the first line of testing. If you have an active urethral discharge, definitely you go ahead with culture. Apart from gonococci, we are not going to do anything by culture. HSV is also PCR. So if you have definitely ulcers, go for HSV PCR. If you have vague urethritis symptoms without an ulcer or a discharge, go ahead with PCR, which will give you chlamydia and other pathogens.
So you should be concerned about the culture of gonococci only if you have resistant strains. You're suspecting it is antibiotic resistant. Then of course you have to do the culture, get the organism and test the antibiotic sensitivity. So that is very difficult, but you have to make an attempt to get it cultured, and always a bedside culture. Bedside inoculation is very, very important. You don't have to take it in the transport media. Mostly viability is lost.
And
I'd like to add a word, Dr. Vinod. Can I add a word?
Yeah,
Your
sir.
permission?
Yeah, sir.
See, now in the realm of dermatology and venereology, now we have gone a new type of urethritis. It's caused by an old dogs. We name it as chronic persistent urethritis. This is the absence of any complicated, that is the prostate and upper genitals not affected. Now, as Madam has correctly mentioned, even though I'm not a very firm supporter of it, even government medical colleges now, the NACO supplied the kits for the syndromic treatment. Of course, it has got certain pros and cons. But now the syndromic, for example, for urethritis, we give the so-called gray kit, which treats both gonorrhea and chlamydia. But in spite of that, during follow-up, they say follow 7, 14 days, you find there's still a urethritis. Seventh day, patients got symptoms, we give 2 grams secnidazole. Then after 7 days, it's persistent. We use the term chronic persistent urethritis. Of this, now a very old organism is implicated. It's a big headache, that is Mycoplasma genitalium. Most of them are actually now also resistant to the maculate antibodies. That's a big problem being faced by us venereologists. There are some regimes that we follow a CDC regime for mycoplasma, that is doxycycline followed by moxifloxacin. That is when previously in the urethral discharge syndrome, we used to give cefixime and plus 1 gram azithromycin. But now even gonorrhea we can resist to it. Now we give ceftriaxone 500 milligram plus doxycycline 100 milligram BD into 7 days. But mycoplasma genital now is even developing resistance to the quinolones and the doxycycline. This organism is now causing headache for us.
Sir, how do you see this chronic persistent UTI? Is it only symptoms
chronic
or a
persistent
persistent
urethritis, a person not responding for treatment given for gonorrhea and chlamydia.
Okay.
That is 7 days after we give one second dose, because in males, especially trichomonas vaginalis also can cause urethritis. After that, the 7 days, that's 14 days after the first episode, after being treated for gonorrhea, chlamydia, and trichomonas, if there is a persistent urethritis, and provided the patient does not have any complicated upper genital tract involved, and provided the patient has taken the drugs correctly, we go to this chronic persistent urethritis. It can be diagnosed by all the techniques we have said, but it is nowadays very resistant to most of the first line antibiotics. It's actually the problem faced worldwide now.
Now the problem is in most of these patients, they may be who are branded as prostatitis or a chronic prostatitis for that matter. And some of them may come as a Dhat syndrome, like some discharge from the urethra. These are all kept in a corner, and they may be given some treatment and leftovers. So that is why we have put these topics into discussions to know what are the things which we are missing, or in what way we can help these patients. Because this is a common problem in the urology OPD. At least 20% of the patients per day will be some form of urethritis. Either it is a chronic prostatitis or some discharge coming to all the andrology clinics.
So ideally, it will be nice that you do a routine culture of all these secretions to see whether there is any enterobacteriaceae. And you ask for the count also, otherwise it will be ignored as no significant count. Because unless we get more than 100 colonies in an untreated patient, we don't actually consider it as significant, because all these uropathogens are normal flora present in the urethra, which may come up in the urine sample or the massage. So unless you actually make a comparison with as that 4 glass technique, you are not going to get a correct result for that. So you ask for a specifically for the colony forming unit count. Okay, CFU you have to ask for, only then you can make a comparison.
Is mycoplasma also detectable in a PCR?
Yes, mycoplasma PCR. That is a frank PCR, NAT, not NAT, yeah, PCR. PCR is done, open real-time PCR is done for
So
mycoplasma.
how this NAT is different from a PCR?
Any nucleic acid amplification test, you can call it NAT. PCR is just one of the NAT techniques. But PCR, the problem is you should have a good setup, a laboratory setup for the DNA extraction and everything. Like we do in COVID, you need specialized labs for that. Whereas for NAT, you can even do it on a tabletop with TrueNAT machine or Gene Expert, CBNAT machines, like we do for tuberculosis now. So you can do it over the tabletop itself. You don't need a sophisticated laboratory for that. It is very fast also. But real-time PCR, you need a laboratory setup, which is very unique for doing PCR with 4-5 rooms. And this is actually done. As you all know, we were doing it for COVID, and the laboratory setup. It is very difficult. Everyone will not have the PCR setup, but NAT, if anybody can make a setup for NAT test, even say in a very laboratory with very less equipments and less facilities, you can do a NAT or that is CB-NAT or TrueNAT test, which is actually basically the principle is PCR only, but you can do it even in the tabletop.
And what about the private sector in the DDRC and in KIMS? These are all available?
Yes.
Yes,
If
sir.
you have a good volume, you can do it in-house, but there are labs which you do the NAT and turnaround time is 1 day. So even if you don't have that volume, you don't want to invest, you can tie up with any lab that does it, and it is turnaround time is 1 day. And surprisingly, you may find more than one pathogen if the patient is having multiple partners. That is why when we give combo for everything like chlamydia, gonococci, and sometimes we may even find trichomonas. So it shows sometimes they need combination of cocktail treatment. So I think PCR is readily available. It can be outsourced, and the TAT is only 24 or maximum 48 hours if it's done outsourced.
I
And
think mostly the delays for the transportation and all
Yeah.
those things. Otherwise, CP-NAT will take hardly 4 hours.
Yeah.
TrueNAT will take around 2 hours, and PCR also we can finish within 4 to 6 hours. But because of the actually private sector, what they do is they pool many samples and then they take it, and there is some transport delay is there, and all that delay is causing the delay in the result. Otherwise, for doing the test, actually you don't need much time. If you're doing an isolated case, it will take some 4 hours, or even say for PCR, it may take around 6 hours or 8 hours. But when you're pooling and you're taking and doing it together, it will take a lot of time.
What is
Abhijit,
important is you have to get the transport media and the swab correctly. And whenever you take the swab, we have to, break the swab stick and put it in the viral transport media and follow the methodology of transport. That is important.
there also the swabs are the cotton swabs, or is it a Dacron swabs you are using?
Dacron or rayon, you should not be using cotton swabs.
So usually they provide, the labs provide with the viral transport media, which is a tube, and this thing, the swabs. For HPV, it is different. It is not the Dacron. It is actually for the women, it is a different swab and the container is different. So whichever lab you are tying up for whatever the PCR, you have to follow the same, the transport media and the swab that they provide. And HPV alone can be done for those anal warts for which the swab may be different. I think Dr. Shashikumar may be knowing and explaining
Yes,
it.
yeah. For a human papillomavirus in females, we have to take a pap smear.
Pap smear.
Pap smear has to be taken, and that material has to be transported. Even endocervical swab you can take for gonococci also, but for human papillomavirus, it is usually the pap smear, which usually is it's sent to the pathology department for seeing the atypical cells, but that is not a good diagnostic procedure.
PCR, for the PCR.
Pap smear you can take and put it in the PCR UTM or the VTM, whatever is
VTM.
supplied.
The swab can be, if it is for the PCR, you have to put it in the VTM medium.
VTM.
And Dr. Abhijit, what is your experience in the Kochi side?
Same, sir. What Rajalakshmi ma'am told, within 24 hours, that time we will get the result. We've got all the techniques, that is, and we are in tie-up with many other outsourcing too. That in 24 hours we are getting all tests done, and we have a panel that earlier ma'am told, multiplex thing and all. We use all that panels.
And Dr. Sashkumari, Dr. Suresh Bhatt has a question posted in the chat box. What about H. pylori in chronic prostatitis? You have any comments on that? H.
No, I don't
pylori.
know. We haven't encountered it, but H. pylori, you have techniques like you can again PCR is there, but actually I have not heard of any case. Maybe it is there. I don't know because it is actually a pathogen which is present in the upper GI, upper gastrointestinal tract, and usually we have the pathogens of the lower GI causing the urinary infection. So it is very unlikely that H. pylori can enter into the prostate, but I don't know whether there are any reported cases.
And Raghavendra or Vineet, any
So there is
request on
one
that?
question to Dr. Rajalakshmi. Ma'am. There is a herpetic treatment, herpes genitalia, recurrent herpes. What is your protocol?
Yeah, so again, we check for the monogamous relationship or whatever sexual protection, or is this relapse or recurrence. Sometimes they get recurrent. More common we find in certain group who are, highly sexually active and having multiple partners. But we have seen these recurrences more commonly in women, though they are adequately treated and remain monogamous. So in that case, we give chronic suppression. We have seen this more common in HIV population, but even otherwise. So after initial treatment, we give at least 3 to 6 months of prophylaxis. If it's Valgan Val acyclovir, it's 1 gram OD. And then we stop for a month and close follow-up. But still, few get recurrences sometimes, but usually they do well. So some percentage of population will need prophylaxis for many months.
So is there any difference between acyclovir and valsiclovir in the efficacy?
No. So only that actually the compliance is better with the number of pills coming down with valsiclovir.
It is 1 gram only.
Yeah, for the prophylaxis.
So we had a very long discussion of around 2 hours and 15 minutes. I think it was very useful. At least I had all my answers, and I think Raghavendra and Vineet
Yes,
will
sir.
also
Yeah.
agree to me. It was an enlightening session for the urologists because we are sure that we were missing so many points, like how the sample was collected and the number of gonococci or the urethritis we are missing, and the Pradeep sir was focusing on the VDRL screening, how it is important, and we can actually save more patients. And all the panelists, Dr. Shivmari has completely covered the whole topic, that the discussion on purulent discharge has become non-existent. So it is already every questions were covered in that presentation.
Thank
And
you.
all the faculty has contributed to this discussion. And any more questions, one or two, if you want, we can do it. I think there are more questions coming up in the chat box. Towards the end, why the prevalence of HIV is coming down, but STI are not so? That is Dr. Manikandan's question. Why the prevalence of HIV is
I have
coming down?
answered that
Yeah.
because many people are worried about HIV, especially the young population who accidentally get exposed. Their only worry is HIV. So when we counsel them that other infections are equally contagious, including hepatitis B, syphilis, they know that those they're not stigma. So they usually come for PEP for HIV or pre-exposure prophylaxis. And because of that, they get confident, and then probably they don't use the physical barrier rightly, and then they come again acquire other STIs. That's an important risk factor, that with PEP and PrEP, pre-exposure prophylaxis for HIV, other STIs are coming up because they are not getting adequate prophylaxis or treatment for other STI. And because of their only worry is about HIV. So at each encounter, I discuss about the risk of syphilis, hepatitis B vaccine. That is an opportunity to give the hepatitis B vaccine. So I check their anti-HBs titer and so on. So we'll have to counsel about all the STI, group them together. But their social stigma is only for HIV.
Now I thank all the faculty for contributing to this meeting, and I will try to summarize it and distribute to all the urologists who have come here, so that this will be useful whenever they are seeing a patient, even though they couldn't follow all the points which were discussed now. So thank you all once again.
Just Vinod, I think I will put in one question in the end, because I just remembered there was a patient, this pre-exposure prophylaxis. This is very, very true. You know what Dr. Rajakmi just mentioned. Patients are only concerned about HIV. In fact, I had one patient. He came with one question, which I want to ask now. He also had this concern about syphilis, and he said, and he wanted to be certain that there was no. He asked about the longevity of the VDRL positivity or the RPR positivity, because TPHA, I know, will practically persist for a very, very, very long time. But he wanted to test his partner and know how he could be certain that there was no past infection. What guideline would you have regarding that? I may have missed that.
Okay, so the guideline is if the positive syphilis patient is treated adequately as per their early primary, secondary, or tertiary based on the adequate doses, they are expected to have a 4-fold drop in the RPR at 6 months and 12 months. If they have 4-fold decrease and further decrease, they are safe, they're not transmissible. But if they don't have 4-fold decrease, then you have to know, you have to understand whether still the patient is monogamous or having high risk behavior still, and whether they have neurosyphilis, or they are actually resistant to penicillin, or they are not compliant with the treatment. There are so many things that can happen. So we have to review, and they are still transmissible. This holds same for the pregnant women who in reproductive age group who wants to get pregnant. Same applies to them. So we counsel if the 4-fold decrease is there, and when they are actually planning to have a baby and the partner is negative, all this applies. So we expect 6 to 12 months for the titer to come down. And by 6 months, they're definitely not transmissible if the titer is coming down.
No, this is assuming that you would be following up this patient. I'm talking about this gentleman who is coming for a prep for HIV and also wants to be certain that he will not get infected with VDRL. So he's just getting his partner tested, and he's asking what is if she's had a past infection, what would be the time for that to have gone?
They have to, as the timeline says, you have to have a repeat test, and the earliest test, like which is FTA-based, we may miss. So it will take few weeks to become positive. And if, as per the general guidance, if the patient is cisgender and is supposed to exposure prophylaxis, there is also a recommendation to give doxycycline along with HIV. This doxycycline will take care of your syphilis and chlamydia infections, which are again transmitted by sexual transmission. So if the patient is cisgender and has coming for a HIV post-exposure prophylaxis, you can counsel for doxycycline. And if he is not sure about his partner having syphilis or in the window period.
I think in the present pace of social dynamics, days are not far when two partners who are going to be partners or getting married may come to us and ask, you make sure that both the partners are not having any STIs and we don't get anything. Because these questions will be very puzzling to us, and sure the andrology group is going to get at least some of them coming up. I think it is better to refer it to the ID friends and the dermatology friends rather than answering this question, because this is a very, very tricky situation for all of us.
Yes.
So thank you very much. And once again, I express my gratitude to all of you for being part of this meeting. It was a very interactive meeting, and all our queries are answered. Thank you.
Thank you so much.
Thank you.
Thank you so much. Good night.
Thank you.
Thank you, sir.
Okay.